All right, I'm going to take over your screen if that's okay. Hello, everybody. How are you doing? And that you can't speak, so I apologize for asking a question, but please type in the chat. Without further ado, we're going to get going and talk about trying to get some energy back. I would love to have this as a live presentation. We'll have, feel the energy in the room, but I'm just going to go ahead and imagine it for now. Without further ado, thank you so much for having me. Thank you to the HealthTree Foundation. Thank you to all y'all patients and families out there for attending today. And please don't be shy, and please feel free to put any questions you have in the chat. We're going to try to get to as many as I can. These are my disclosures. So first, I just want to take a step back and talk about the discovery, quote unquote, of lymphomas. This is going back way in time. So lymphomas can present in many, many ways. They've affected people for thousands and thousands of years. And they were noticed by ancient Egyptian healers, for example. Here's the first documented cancer, which actually probably was a lymphoma from about 5,000 years ago. There was no microscopes back then, no blood chemistry panels, just another cancer for millennia. And people would unfortunately have disease progression and get sicker and die mysteriously. It wasn't until 1832 when Dr. Thomas Hodgkin, so you'll hear about Hodgkin and non-Hodgkin lymphomas today, briefly, was credited basically with being the first to try to subclassifying lymphomas and use the light microscope. This was the Reed-Sternberg cell, which was kind of characteristic of Hodgkin lymphoma. And because that was the first identified, it was the first to get a name. So it was called Hodgkin's disease and now called Hodgkin lymphoma. Over the last 60 years, and especially the last 5 to 10 years, the field has been evolving incredibly rapidly, and it's always a challenge. It's always interesting. We're always getting better and more sophisticated. Unfortunately, as we'll talk about, some of the side effects, including fatigue, are also changing with some of our new treatments. More people are surviving, with many lymphomas or CLL, and with multiple rounds of treatments that were really non-existent before, all can have their own side effect profiles as well. So we'll talk a little bit about that today too. So the progress has created new problems as well as improved outcomes. Just taking another step forward. So now this is based on our 2022 classification, our latest version of the WHO, our World Health Organization, 5th edition of how we classify lymphomas. There are actually 49 mature types of B-cell lymphoma. 2 of them are actually called Hodgkin lymphomas. There's really only one, in my opinion. NLPHL folks out there, I hate to say, but you kind of have a follicular type lymphoma, a little bit different, but by and large, most lymphomas are non-Hodgkin lymphomas. And then here's just kind of a simpler breakdown of our classification system for your awareness. And then looking at T-cell lymphomas, there are about 39 subtypes of T-cell and natural killer cell lymphomas as well, based on our recent classification. And the whole point of me showing you all these different subtypes of lymphoma is to show you how complicated this really is. And just to highlight this a little bit further, going back from ancient papyri with large masses in people who were tired and sick and then mysteriously died. In the ancient days to the light microscope. Now we have molecular studies as well as advanced immunohistochemical approaches, which really were pioneered in the 1970s, like on the button panel B. And then things like FISH or fluorescent in situ hybridization, chromosome studies started really in the 1980s in earnest. And now we're working on gene expression profiling and multiomics as well. So we're getting much better at subclassifying lymphomas based on their molecular properties and unique subtypes. Even within those 111 subtypes of lymphoma, we're getting better at breaking them down into their molecular characteristics and driver mutations, et cetera. And so with our improved understanding, we're also getting better treatments, and just wanted to advocate for tailoring therapy, trying to get the best possible efficacy, best outcomes, and trying to avoid toxicity wherever we possibly can using data, right? And fatigue, unfortunately, is one of the side effects that's very common. We'll talk about with lymphoma treatment and living with lymphoma and CLL. And it's basically now we have more options. So just to highlight CLL, many of these treatments are also applicable to lymphomas as well. We have a burgeoning landscape of targeted therapies and cell therapies and new molecules coming all the time, and CAR T products and bispecific engagers and things like that. And basically, these can all have their own unique side effect profiles. Many of them, of course, are on clinical trials, and uh, side effects are captured on clinical trials carefully as well. I also want to give a shout out to Dr. AJ Major. If you haven't heard of him yet, he's a friend and a pioneer at the University of Colorado. Really all about patient-reported outcomes as well. And it's something that we're increasingly incorporating into our clinical trials, including a Richter's trial I have open at Roswell Park as well. So trying to make people feel better, live longer with their cancers, want to stay on treatment. And of course, efficacy we talked about first, but the toxicities and trying to tailor our treatment approaches now with more options is becoming increasingly important, and that's great news. We're not there yet by any means, as many of y'all will know from personal experience. Lots of chemotherapy we'd like to get rid of in the future, but we're not there for unfortunately, many cancers we still don't have some of these fancy options quite yet, but we're coming. As far as the demographics of lymphoma, I think it's important to highlight that collectively non-Hodgkin lymphomas represent the 7th most common form of cancer and the 8th deadliest overall. Leukemia tends to steal CLL, so leukemia actually would be a little bit more common as far as cause of death in the United States, but generally patients with CLL have an excellent prognosis and live a long time with their cancer and tend not to die from their cancer, fortunately nowadays with our targeted therapies, but still a major problem and relatively still fairly common group of cancers. And then looking at non-Hodgkin lymphomas collectively, they typically will affect patients in our 6th and 7th and 8th and beyond decades of life. And so lymphoma and CLL typically affect older adults. And why do I bring that up? Not to be ageist, but really to also focus on the fact that comorbidities, other medical problems, things like cardiac disease, things like COPD, if people were smokers, diabetes, obesity, et cetera, they tend to become, unfortunately, more common as we age. We're subject to entropy and decay and aging. Hopefully we'll have a cure for aging at some point in the next, 20 years, but I wouldn't bank on it just yet. It still goes back to healthy diet, exercise, and talking to your primary care and co-specialists and getting your regular cancer screening, et cetera, to ensure optimal health. Of course, one of the notable exceptions are going to be Hodgkin lymphoma. So the one I just briefly introduced in the beginning, the OG lymphoma, and ALL typically will affect patients in a younger age, including in kiddos. But by and large, collectively, again, of those 111 subtypes or so of lymphoma, older folks tend to be affected disproportionately more. Now, how do lymphomas present? So they have a very highly variable presentation. Again, back to the biology, very different biologies in different people can cause all kinds of different issues. Aggressive lymphomas or bulky indolent lymphomas, so slow-growing lymphomas, tend to cause what we call B symptoms. These are characterized by fevers, 100.4 Fahrenheit or over 38 Celsius for us who are not scientifically inclined or in the US. It has to be proven to be unrelated to infections, unintentional weight loss characterized by over 10% of body weight loss in 6 months, unintentional, not on a GLP-1 and happy with it. Night sweats tend to be drenching and but often can be damp. We call it the damp phase, where fatigue tends to be insidious and sneak in there as well. Fatigue is not technically labeled as a B symptom, but I lump it in there as well. It does definitely commingle with these very frequently with the burden of disease. Lymphadenopathy is defined by enlarged lymph nodes. So very typical of many lymphomas is going to be lymph nodal involvement, not for all lymphomas, of course, but many. And then we look for things, emergencies like tumor lysis syndrome, where the cells are breaking apart with or without treatment. Typically very aggressive lymphomas like Burkitt lymphoma, double hit lymphoma, you'll see that. Big compression syndromes, effusions, so people can be very, very sick. People can have anemia, people can have low platelet counts. That can certainly take a toll if patients have low red blood cell mass, and you need red blood cells to carry oxygen around the body. I do have some studies. I didn't put all the figures in this, but there are plenty of literature showing that if you're anemic, you're going to be tired. And I think, unfortunately, personal experience or seeing other people affected by anemia, you can see it. Treatable, going to get rid of the cancer, try to pick therapies that can mitigate that risk as much as possible. You can get CLL and other low-grade lymphomas typically can cause an antibody-related breakdown of red cells as well. You can get hyperviscosity syndrome with LPL, for example, or Waldenstrom's macroglobulinemia. Occasionally, you get that for marginal zone lymphoma as well, and that can cause blurred vision, severe fatigue, heart failure-like symptoms as well. So again, got to be careful. And of course, infections can also cause fatigue. We'll talk about that too. But these are all potential side effects of having lymphoma or being on active therapy. Fatigue is very common in lymphomas and CLL. It can also be very insidious and multifactorial. With indolent or slow-growing lymphomas, which are quite common, including CLL and follicular lymphoma, for example, they can also present similarly. And there's this kind of horrible allegory of a frog on a stove. I don't know who has ever done this in the past to come up with this kind of phrase, but if anyone's ever heard of a frog sitting there, the water's kind of cold when you start, then you put them on the stove. Apparently, this is sick and twisted, and I've never done this for the record, but it can be kind of like that as far as just this gradual, slow growth and insidious onset of symptoms or other problems. And it's kind of like being a frog on a stove. And many patients will describe this kind of sort of Damocles effect of living with a chronic illness or chronic and highly manageable lymphoma. You might hear about all the excellent prognoses, best treatments we have. Still takes a significant mental toll on people. And that certainly can cause some fatigue as well. And I want to highlight some resources at the end to help people know that you're not alone. It's a common thing to feel. And we do have some ways to get rid of things. We're trying to cure these cancers. That's certainly top of mind, but right now they're pretty toxic treatments to even attempt to get the cures for some slow-growing lymphomas like CAR-T. And so, unfortunately, we're still stuck with living with a lot of these cancers for the short term for many people. So I have a case example. This is a Mr. Jones made up, fictional character. This is a stock photo from the internet. 72-year-old man with a history of high blood pressure, hypertension, high cholesterol, and a prior heart catheterization with a stent placed, who had double hit lymphoma, presented with some B symptoms, again, some night sweats, fatigue, loss of weight, appetite, etc. Large lymph nodes in his neck, armpits, and groin with some belly discomfort. So he's already had his one cycle of kind of emergency chemotherapy, and now he's had a little bit more time to kind of contemplate life and how he feels. And, the heat is kind of off a bit, but now he's starting to feel tired. And, now he's admitted for cycle 2 of chemotherapy in clinic, about to be admitted. He's reporting some trouble sleeping in the hospital. He's had some intrusive thoughts. He's taking more medications for nausea prevention. So I wanted to just take a quick poll, if you don't mind throwing some ideas in the chat of potential causes of fatigue for this poor man with a curable lymphoma, I will say. So double hit lymphoma is an aggressive lymphoma, but feel free to put some ideas in the chat of causes of fatigue that come to mind, and we'll talk through some of them. And just leave maybe 15 seconds to type away there. And otherwise, don't worry, we're going to talk about it at the end as well. And all right, so I'm going to keep going here. So first, I want to say, lymphoma by itself, right? The disease itself was killing him actively. He was very inflamed. He had bulky, compression. He was anemic, probably from blood, bone marrow involvement by the lymphoma as well. It's a really nasty, aggressive lymphoma. He had a lot of disease in the beginning. After cycle 1 of chemo for this kind of lymphoma, typically 80% of that cancer is going to be dead, which is great, or more. Occasionally, people will order scans willy-nilly. Usually it's after 2 cycles of treatment, we'll do a scan, but sometimes people just get trigger happy. They order one after 1 cycle, and you'll sometimes see complete remissions just that early. Generally, you expect that later on throughout treatment. There's inflammation, right, from the lymphoma itself, and then from dying lymphoma, and then potentially from some infections that can sneak in along the way as we take away the immune system, right, to kill that cancer. Again, low blood cell counts, anemia, certainly very stressful, right? New life-threatening cancer, life-changing experience, right? So being on chemo itself certainly is a direct drug effect, including worsening the anemia in the short term, expecting it to fully resolve gradually over time in the long term. Pre-medications like Benadryl or hydroxyzine with rituximab infusions, for example, that can definitely cause fatigue, particularly on that first day, and disrupt sleep patterns. Putting people in the hospital certainly can do that as well. Again, stress. There's this fear of the unknown, this situational anxiety, depression, right? So mental health issues that are situational and very much expected, frankly, and treatable will emerge. And then other things to consider for, especially for this patient, history of heart problems. You have to think about heart disease. Fortunately, he had an echocardiogram done in the very beginning of treatment, and his cardiologist is aware, and he's been doing fairly well with good stress tests. So the concern is less for this gentleman, let's say. But in general, I've seen patients say with low-grade lymphomas or CLL, for example, having disproportionate amounts of fatigue. And I try to torture people with not actually, but doing an exhaustive medical workup before I will actually treat somebody just for fatigue. So if they don't meet other treatment criteria or guidelines, fatigue by itself, ultimately for me, is something that I'm trying to whittle down other causes at the same time, knowing of course that full well that having the low grade, low burden blood cancer certainly can cause fatigue as well, as for the reasons I just mentioned, the stress, the sort of Damocles effect, the biological inflammation, some mild anemia, et cetera. And basically for a couple of patients, I've referred for cardiology, stress testing and found they had triple or quadruple, coronary disease, right? And they had their stents placed and now doing great, right? Without any treatment for their blood cancer because we found the right problem. Same with sleep apnea, same with thyroid issues, same with depression or anxiety of other causes. Right, other medications. There's a whole list of things that you have to consider as far as other causes of fatigue, and then malnutrition. Right, so this gentleman had a bulky abdominal involvement, let's say, by lymphoma as well, and couldn't eat very well, and maybe wasn't taking a multivitamin, and his overall food intake was not very good. Want to show one curve from a publication. I'm going to expand more on the next slide from Dr. Wong et al., but just showing that albumin, which is the major protein in your blood after antibodies, actually before antibodies, so it's the dominant number one protein in your blood, does go down with inflammation and goes down with malnutrition. So you need building blocks of proteins to make protein in the liver, actually. So if you have liver failure or kidney losses, let's say with amyloidosis, for example, or direct renal involvement by a cancer, less common for this talk, but in the myeloma world, that's more common. LPL, marginal zone, you have to think about those. But basically, if there's a low albumin level, fatigue definitely tracks with that. And again, it's commingled. So we'll talk about that again on the next slide right now. So fatigue is very common. So 47% of patients in one study, this is a large study, thousands of patients, just gave you the citation on the bottom there for reference, and there's many others as well. But about half of patients with CLL and non-Hodgkin lymphomas will have some degree of severe fatigue. So not just mild fatigue, like I feel all the time, being a father of two toddlers, or two young kids, I should say now. But it's severe, right? Affecting your ability to take care of yourself, affecting your ability to do your independent activities of daily living. We call them IADLs, right? So life-altering, mood-altering, et cetera. And often fatigue is going to be mixed with other symptoms. So we're talking about gastrointestinal symptoms, nausea, diarrhea, right? If you're pooping all the time at nighttime, it's hard to sleep, right? You're going to be awake a lot. Sleep disturbances, again, if you're stressed out or taking medications that can alter your sleep cycle. There's cognitive impairment in a pretty significant minority of patients with lymphomas and other blood cancers like CLL. Pain, certainly we can treat pain. Killing cancer, for example, can hopefully take away the pain completely if that's the cause. Infections, weight loss, malnutrition, lots of other things can affect the fatigue. So just know that fatigue is a really, really general symptom, very common symptom, and it's really worth exploring further with your medical team and your doctors locally. You really want to, explore all those potential causes and be mindful of them, and try to take steps. And I'll show you my little recipe, quick and dirty recipe at the end. Just know, of course, that treatments are also likely going to cause fatigue as well. So chemotherapies in general, if you look at the spectrum of different lymphoma subtypes I just went over, Hodgkin lymphoma, diffuse large B-cell lymphoma, some of these T-cell lymphomas, mantle cell lymphomas are often treated with chemotherapy. So you see a lot of the chemo-heavy treated diagnoses here on the right, having more fatigue related from treatment. But it's pretty common across all blood cancers, including things like CLL, right? So venetoclax or the BCL2 inhibitors or some of the antibody drugs with Benadryl, pre-medications are also pretty common as well, but less common than heavy chemotherapies, these curative intent, aggressive cancers. tend to hit them really hard, and we hit people really hard during treatment as well. So about half of patients have fatigue from treatment overall. Less if you look at this study, for example. As we get older, the incidence of fatigue goes up, and then cognitive impairment is certainly underreported and a big problem. It can also cause fatigue, and up to a third of patients will experience some degree of cognitive impairment with a blood cancer or with treatment, and 8+ years or longer, actually. So it can actually be a pretty long-term, unfortunately, side effect. And one of the reasons you think about that can be direct inflammatory changes from chemotherapy. There's a lot of mechanisms for what we call chemo brain, very multifactorial kind of syndrome. And it's really important to try to unpack and treat as many of those potential causes as you possibly can with your primary care doc, and occasionally with supportive psychotherapy and other medications as well. And just know that 74% of patients with cognitive impairment, so of those one third, 3/4 of those patients will have some significant fatigue, and oftentimes with some psychological distress from that combination of cognitive impairment and fatigue. So unfortunately, far too common. So just briefly, how do we manage fatigue? So number one, I can't urge enough, is to try to unpack some of those causes of fatigue. Talk to your medical team. Let's go over the labs. Let's go over the other health problems that you might have, or your loved one might have, and look at the medication lists. Make sure there's adequate sleep. Look for sleep apnea. Look for cardiac problems, etc., liver problems occasionally. And try to avoid alcohol use as much as you can, or heavily sedating pain medications wherever possible. Develop a care plan, right? So there's supportive medications, counseling. I can't say enough. It's amazing, right? Just talk therapy, referrals to survivorship or supportive care clinics. Primary care doctors and offices often can help as well. We have plenty of organizations, including through HealthTree or groups like Blood Cancer United, with free nutrition classes at Roswell as well. All these things can really help a lot. You want to monitor your fatigue. I can't also emphasize enough how important it is to try to write something down. Journaling is really important and really useful for us as doctors and other caregivers, to really try to quantify your symptoms. And we can actually, if you have dates, you can even try to link it with your lab work, look and see if it does it track with your anemia, does it track with your timing of, say, a treatment cycle, does it track with how much cancer you have, for example. And then really, it just kind of helps kind of piece together this puzzle, right? It's a shared decision, shared management plan. We definitely are going to need your help to try to track this down and sleuth a little bit. And then I can't say again enough how important it is to build a support network. You are not alone. Know there's tons of resources out there, and don't be afraid to speak up, right? So if something's wrong, you're not happy with your care, advocate for yourself. Second, third opinions are always valid. I said it on our last HealthTree webinar, the Lymphoma Day and Precision Medicine talk. Speak up for yourself. You deserve to have the best care wherever you are. And just my shameless plug with Hannah, who's out on leave. We built this survey to living with lymphoma, how fatigue shapes daily life. Here's the general HealthTree website, but you're going to get a specialty link if you signed up by email, and it should also be searchable on the website as well. But we'd love to hear more about your own experiences, and would want to leave some time for some questions and discussion.
It was wonderful. Thank you so much, Dr. Cortese. I feel like you went over so much of what patients are experiencing. As Dr. Cortese said, this is your time to ask those questions. We've got some that have already been populated in the chat, but if you do have a question, feel free to drop that in the chat. We do want to keep these questions towards fatigue or fatigue-related questions. If you do have specific questions around your care, those are best answered with your care team. But if you do have questions, drop them in the chat, and if they're a little too specific, we may try to make them a little bit more general. There was one question in the chat asking about insurance denials. I want to let everybody know we do have a financial Q&A tomorrow at 6 p.m. Eastern, where you can ask those questions in advance. You can also ask them in person. So I'm going to deter that one and recommend that they join that financial Q&A event. But I'm going to just start up here at the beginning. They're just asking about brain fog. And is brain fog a part of fatigue, or is it a separate symptom altogether?
It's a great question. That was I think, second to last slide I had. Brain fog is unfortunately quite common, especially with intensive chemotherapy. It's also unfortunately common with things like CAR T cell therapy, especially if people have ICANS, right? That neurotoxicity. And that by itself is more common if people are inflamed with lots and lots of cancer going into CAR T, for example. That's a whole new area of exploration there. Certainly, if there are, there's antecedent, or pre-existing cognitive issues, right? And so, oftentimes, unfortunately, that can be hidden, right? So, if someone's eaten cheeseburgers their whole life and, drank a pint of vodka, every day, right? But they feel like their brain is fine, but then you go through chemotherapy, compared to a marathon runner, vegan who's had their cholesterol well controlled and optimized for decades. You're going to see that the incidence of brain impairment and brain fog is more common in those patients with other risk factors for dementia, for example, or vascular disease. And oftentimes, our brain can cover up things, really sneakily, right? If you live with things for long enough, right, you can cope, you can adjust, right? So there's this ability to compensate, right, for a deficit that may not actually exist, may not be visible. It's kind of hidden. We call that subclinical in the business, right? So it's not a clinical symptom or syndrome yet, but you're at risk and you don't even know it. So that's where that good, clean, healthy living really comes into play. If you have the luxury, of course, of planning for the future, many people don't, right? We've lived our lives. We come in with what we got, and we got to live with it, right? We got to manage it. So, but brain fog generally it's complex. It can be biological and it can be mental, and oftentimes they're actually intertwined, right? So there is usually a physical problem. Whether or not we're smart enough to figure that out precisely is a different matter. I leave that to our neuropsychiatrists and our geriatricians and neurologists. But different parts of the brain can be affected differently. And there is some literature on brain fog from chemotherapy in particular, but also from, say, for example, I see a question on Waldenstrom's, for example. So that's a syndrome where I would look at the IgM level, right? Look for hyperviscosity syndrome. It can be very sneaky. So in general, an IgM level over 4,000 for me, I'm really looking for blurred vision. I'm looking for foggy thinking. I'm looking for shortness of breath. I'm looking for the trend on the lab values over time. I'm looking for weird skin rashes, neuropathy. If you get neuropathy from treatment, it often can be commingled with brain fog because these are neurotoxic drugs, for example, with anthracyclines like doxorubicin, and CHOP and EPOC and stuff like that, or with Hodgkin treatment. So, and then immunotherapies are a different whole beast, right? The immune system also can kind of drag on people, make you feel tired, just like you're fighting the flu, for example. You feel tired. There's a cytokine whole communication network in our bodies that also has neuropsychiatric implications. And then you have to look at the gut microbiome even now. So, right, are your gut microbes healthy and intact or not? 40% of your neurons live in your gut. So if you have a lot of gut issues from treatment or from frequent antibiotics and kind of or a crummy diet, for example, you got to have some veggies in there sprinkled in, well washed now, especially these days, right? But really, that malnutrition can be a sneaky thing as well. So you want to be careful with that. Tons of nutrition courses out there, support network. Food is too expensive right now, but there's still plenty of options out there to help. And again, that last bullet point is please speak up, right? There's usually many more resources available than you even can think about. So keep asking, and we're happy to help.
That's
Um,
perfect. Thank you.
Welcome. And I'm looking through some of the questions here, some detail ones. So stress I'm seeing coming through and bad sleep. For that, I know many of us hate to talk about our symptoms and how we feel, including myself, frankly. But I can't argue and advocate enough for some form of psychotherapy or at least some supportive care. Like for example, at Roswell, we have a 11-day power play. It's a hockey focused lounge, for example, and a whole bunch of support networks in place. A lot of these can be also confidential, right? You can do virtual appointments as well nowadays. So, if it's too stressful and too stigmatizing to seek some kind of mental health care, just know that there's lots of ways to do it short of coming into like a group session, for example. That's that takes a lot of bravery, in my opinion, to do that. But just know that a lot of those things can be talked through, and if nothing else, please talk to your doc, right? Please talk to your medical team. They know you the best, or they should, and they can do testing. They can help with some of these referrals in a HIPAA compliant private way as well. So just know that there's a lot out there for that. um, of course, you also the one of the things you have to look for, it's rare. I'm seeing like, mantle cell lymphoma occasionally, very rarely, incredibly rarely for CLL, but certain types of blood cancers, God forbid, can also present with brain involvement. So it's something else to keep in mind. If you're tired all the time, you're confused, brain fog, oftentimes I'm going to be getting imaging. I might be talking about a lumbar puncture with testing like cytology or flow cytometry, right? Looking at the fluid from a lumbar puncture. I don't like to do that for many people, but for a lot of high risk cancers, we will. It's something to, God forbid, if things are getting worse, not better, make sure that your oncologist is paying attention, right, for those kinds of horrible things. And those are actually treatable now. So we actually have plenty of treatments that can actually get into the brain and actually sterilize the disease there as well, including things like CAR T and targeted therapy. So um, let's see. Ms. Cindy, I'm going to ask you to summarize any other questions that you can pull out for me for the chat.
Yeah, it got a
Hopefully,
little bit busy in there.
sorry.
Just got, no, you're good. One question in here, just asking about supplements to help reduce fatigue. Is that something that there's a general consensus on, or what could you say about supplements?
Supplements, I'd generally be very cautious. By definition, supplements are usually not FDA approved, right? So therefore they haven't gone through some of the rigorous testing and quality control measures. Anyone off the street technically can make a supplement and then just sell it, right? So you could just make a batch of whatever homebrew something, and if the store is willing enough to put it on their shelf or the online store, and there's often a financial incentive, right, to publish and advocate for some of these products that may or may not have actual data behind them. So I often would just really at least talk to your oncologist about interactions, medication interactions. So that's something you want to avoid. Certainly, if you have multiple different supplements and treatments, for example, or other treatments for, say, high cholesterol, there can be interactions between those medications and the supplements that can boost drug levels or decrease drug levels in a dangerous way. So, as long as you're transparent and you've done some homework, I think that's the most critical step. That said, there's a lot we don't know, right? In our Western approach, our scientifically rigorous approach, a lot of things that are promising are not published, or things that are quacky, frankly, are published and harped on and broadcast over the internet, for example. So it's really hard to sleuth through what's truth and what's not. I tend to fall back on publications and scientific literature and our guidelines, and if nothing else, at least some mechanistic studies, right? Looking at experiences that have been published in a reputable journal, if possible. And then our support groups also are very good, and there are specialists who are familiar with some of these supplements as well, especially our supportive care teams and our survivorship teams. Um, so there's plenty of examples of supplements that might be helpful, but there's many, many more, I hate to say, that are more harm than good. So you got to just be very careful.
Absolutely. In that same vein, the topic of integrative oncology comes up a lot. Is there a reputable way or a way that you would recommend people look for integrative oncologists who would work with the person's hematologist oncologist?
So that's the key, is working with, not against, or trying to replace. I've seen, unfortunately, some cases of lymphomas where people have gotten really off the beaten track, non-approved treatments, and including with chemotherapy in other countries. Like, I've seen some weird stuff, and there's been harm, right? The cancer gets, in some cases, has been really twisted, manipulated. People are pretty sick, and then they come back for treatment, and then now they need even heavier, more intensive treatment to try to, overcome some of the damaging effects of their prior exposures. But in general, though, there are plenty of excellent integrative clinics and approaches that will incorporate talk therapy with some supplements, with some helpful medications that are pinpointed, that don't interact with a given regimen, that are awesome. So I would say the best way to do that to start would be to go through your primary doc and your primary oncologist and ask around. You'll often hear that there's things missing, right? And one of the best groups of people that I work with all the time are twofold. We have a whole supportive care clinic. We're very blessed at Roswell. Usually these are palliative medicine physicians that have a lot of experience being more creative, right, with some of these other supplements that might be helpful. And then I would say there are integrative medicine clinics as well out there that are excellent as well. So you have to really kind of vet things through your oncologist and at least let them know what you're doing. I would say at least, especially what you're taking in your body. Again, just to make sure you're not having any harmful interactions that can cause major problems and potentially worsen your symptoms.
Perfect. Thank you so much. That was a very inclusive answer. I really appreciate that.
Pleasure.
We've got a question just asking, I drink 2 cups of coffee a day to help with my energy level. Are there any issues with this?
No, coffee is honestly excellent for you. I get the rare case of certain medications that can interact with coffee. So if you're on other stimulants, for example, that can cause you to be kind of wired. Sleep patterns disruption. If you're drinking coffee late at night, can be a problem. And then the diuretic effect of caffeine is the only other potential problem. Generally, you want to drink a glass of water to at least fill back your coffee cup with some water. Unless you have severe volume issues, then of course I would talk to your cardiologist or nephrologist, for example, for those. But generally, coffee is excellent for you. The rare exception are going to be people with really severe cardiac disease or neurovascular problems, history of stroke, heart attacks. And you just got to be careful with the blood pressure effect and the volume management. But coffee generally, though, is great for the liver. It's great for energy. I love it. Personally, I don't take any money from the coffee lobby or anything like that, so it's generally great. Just I would just make sure that you're aware that it is a drug, right? It does have effects and it can cause dependency as well. So just be aware of that.
Perfect. Thank you. Got another question that says, about 4 p.m., I'm ready to drop. I take a nap. Is that okay to do, or should I try to work through it?
That's individualized, right? So Ms. Jody, for that, I would talk to your doc. I don't know the specifics of your case, but I would say, if you're in the middle of heavy chemotherapy, right, or 97 years old, or that could be very, very normal, right, and expected and manageable, and hopefully very temporary for you. If it's an everyday thing all the time, and you're not sure why, I would definitely try to do a medical workup and look at some of the details on that. Certain medications might make you tired. For example, you take them in the afternoon or the late morning, they can kind of have a peak in the blood and cause more fatigue at that time of the day. Right, sleep clinics, make sure you're getting good rest. Lots and lots of things. That's something I would talk about with your team, in clinic.
Perfect. And I like your suggestion earlier about journaling, just making sure you've got a good record of
Hmm.
exactly what's happening, keeping track of even diet or anything you're taking into your body would be helpful, I'm sure, in evaluating that with your healthcare team. Let's see.
And as far as the naps, I love naps. I wish I could have more naps, to be honest with you, as long as it's you're okay with it and there's no other problem beneath the surface that's at least that's fixable. Certainly, like you always want to recognize if there's a problem. I think naps are healthy otherwise, but if it's all the time, every day, getting worse, not sure why, definitely want to amplify that one. You want to talk that one through. Um,
Perfect.
yeah.
Got a question just about immunotherapy maintenance. Is this something that has been studied to cause fatigue, or is it dependent on the medication?
Definitely depend on the medication for that one. So there are, certain novel immunotherapies like the checkpoint inhibitors, for example, that can cause this immune activation, which you like, just for example, Hodgkin lymphoma, Richter transformation, some others as well. But those are the two most common lymphoid malignancies. You'll see that, gray zone lymphoma, or rather a mediastinal large B cell lymphoma. Gray zone's kind of gone now, unfortunately. But, so you're looking at the potential of actually autoimmune issues in the brain itself. Um, Things like rituximab, over time, generally you're not going to get as much as a fatigue. One thing to think about with that would be, again, a really rare problem that's potential, but would be devastating if you have it, would be something called PML, right? So if your immune system is suppressed for a long period of time, um, you can actually have activation of a virus, God forbid, in the brain, right? It's called the JC virus. And usually that would come with speech difficulty, weakness, kind of discoordination, not just regular fatigue. And that would be a big red flag to get an MRI of the brain. And the checkpoint inhibitors actually be the treatment actually for that, God forbid. It's really rare. Usually the longer you're on a maintenance therapy, right? If you're on for 2, 3 years, as opposed to say 6 to 8 months, the longer you're on an immunosuppressive maintenance therapy, the higher the risks, and just be careful and make sure that there's a management plan. Talking with your doctor, even JC virus in the PCR, JC virus PCR in the blood, even it's a pretty uninvasive way to even do tabs on that. I generally don't do that unless there's some concern that comes up, and then I'm talking MRI anyway at the same time. But it's less than 1%, but it's going to happen usually in those folks who are on really heavily immunosuppressive treatment. Think CAR T cell therapy, and then you add bispecifics after, or rituximab for 3 years, like the old school approach for mantle cell lymphoma, stuff like that. So um, again, really, really rare.
Perfect. Thank you. I think you've highlighted again how important it is to make sure you're communicating very well with your healthcare team. So thank you. Um, Got a question just asking what kinds of exercise might help with fatigue?
All kinds of exercise, honestly, are very helpful. You don't want to helpful. You don't want to fall and break your hip, of course, or anything else. So if it's Buffalo and it's the wintertime, I often will ask people to go to the mall and walk around in the mall, for example, but just gentle cardiovascular exercise. 30 a walk, honestly, is good enough to get your heart pumping a little bit. Know your body, know yourself. If you're at risk for falling, physical therapy is outstanding. There's home physical therapy oftentimes available for people, and you can even do things on the internet, for example. So um, I'd be cautious with those. I tend to look at things like the American Academy of Orthopedic Surgeons, for example, as a really good set of exercises you can do at home, say for back pain or hip pain, things like that, and always kind of vet things through your primary care doc or your oncologist. But generally, you want some general cardiovascular exercise. Weight training, I can't also say enough. Again, without tearing your biceps tendon. So basically, low, manageable, set like 10 reps of something that's very light duty for you. See how your body does. And actually, I also really like the 100-day challenge. So you can do like say, one sit up on day one, and then two sit ups on day two, three, and so on. And you can do different kinds of exercises, a jumping jack. We walk up and down stairs, for example, one flight of stairs you can do, say, once a week, and then two the following week, for example. You can kind of do that gradual intensification, again, making sure that you know your body. If you've got weakness, neuropathy, you're aware of those potential issues and risks, and you have ways to if you catch yourself falling and you can't get up, you have a life alert, for example. You got family to check in with you, stuff like that. But generally, exercise is awesome. Actually boosts your immune system. There's all kinds of data now that, like Megan Herr, for example, at ASH in 2024, one of her oral abstracts was about exercise and improving outcomes with CAR T cell therapy. So people actually going to have less ICANS, less infection risks, less long-term dementia risks, or cognitive impairment risks, I should say, all from exercise. So it's outstanding. Healthy vasculature, healthy muscles, good blood flow, fixes a lot of woes. Honestly, it's really good for your endorphins, helps with stress management. I wish I had more time to exercise. I have probably no excuse. I should just do it. I'm working on it, but it's amazing. So I'm just talking myself into doing more myself now. But um, and then I'm seeing something about 24 months of a Caliven, probably Amplify. Definitely those drugs, certain drugs certainly can cause fatigue. And oftentimes I'll dose interrupt with permission from your oncologist, talking about the pros and cons. If you interrupt for a couple of days for treatment, generally speaking, unless you have Richter syndrome or nasty relapse refractory problem, if it's run of the mill low risk CLL, generally you can interrupt for a couple of days, see if it gets better, and then you want to get back on the horse potentially with at a reduced dose, and then graduate back up to full dose if possible. And if there's no difference, or MCL, there you go. Same. So um, same ballpark. You're looking for, if you're on the drug at full dose all the time, which you're probably doing now, and not interrupting at all. Talk to your oncologist about a very brief planned interruption to see if things change. You can stop one drug, for example, at a time, or just dose reduce. For example, say Ven 400 to 800 milligrams daily. You could try half a dose, for example, for a couple of days and see how that does. And if it's clearly related and it comes back when you restart to full dose, then you know it's the drug. If you've got an end date in mind, and hopefully there's some kind of a fixed duration plan in place. If not, then you have to talk about how aggressive do you want to be? That's a delicate balance of efficacy versus toxicity, quality of life versus quantity of life. And obviously we want both all the time. But I would really just kind of try to unpack that with your oncologist locally. Generally, a very brief dose interruption, dose reduction that's monitored and planned with your oncologist is the key. Is safe to do, and honestly very helpful. Then you kind of know it's not something else, right? If it's clearly tracking with your drug.
Perfect. Thank you so much. You mentioned earlier just the other effects that people may see just generally with age. So we may not be thinking about sleep apnea and different things like that. If somebody hasn't had a good checkup with even a primary care physician outside of, their cancer treatment, um, how important would it be to have their sleep monitored there as well?
Critically important. And I noticed sometimes when patients are on active therapy, certain primary care docs will kind of just take a huge step back and like not even see their patients. I really don't like that style personally. I know there's realities out there as far as patient census and preference and all that, but generally I want some buy-in and I want integration of care, right? I want to have complementary care, right? So we'll definitely handle the cancer and all the drug effects and all the biological implications of treatment, right? Which is a lot of it, but oftentimes I really want a primary care doc to help co-manage the diabetes, the sleep apnea, do the other referrals, the health maintenance side of things. Really, really important, I think, to keep everyone involved and engaged in your care. And if you're not getting that, you can certainly ask for that. And I think that's a healthy thing. And advocate for yourself. It's easier said than done sometimes, but your doc should be receptive, or doc's office. Even checking with a PA, getting a sleep medicine referral, right, would be enough, I think, at least to get started and kind of keep the ball moving forward.
Perfect. And you led right into the next question I was going to say. The big thing that I hear is advocating for yourself can be so difficult. Are there specific terms or specific things you might encourage patients to say if they feel like they're getting brushed off when it comes to fatigue?
I would say this if you use the word serious or greatly impacts, right? If you kind of add some gravitas to it, it's really important to me. Critical to me is even more, that's an even stronger term, right? Like I say, I really desperately need your assistance, right? You just be very, very bold and in their face. And if they react negatively to that, right, then there's a problem with the doc, I'm sorry to say, right? So you really got to, at least, even if you say, I don't know, or I don't have time to deal with that at this moment, but I'm happy to help. Let's explore this at our next visit. Let's try this X, Y, or Z. Some kind of at least menial suggestion is going to go a long way more than just nothing, a total brush off. Total brush off, I would be looking maybe for another doc, I'm afraid, right? So, um, maybe that doc should go into the insurance industry or something. Just kidding, but like so, um, so you should demand a certain level of expertise and care and compassion. It's a privilege to take care of patients. Entrusting someone with your care is, it's a privilege, right? To practice medicine, it's not a right, and you don't have to um, give people business who are not helping you, right, or not listening to you. So you know, yeah, it is what it is. Just know your rights. Know you're worth a lot. You're precious, and um, you know there's no insurance companies and lobbyists might disagree, but I think there's no dollar sign for you. Like everyone's, life is precious, and you're no exception. So um, just know your own worth.
Perfect. Thank you so much. I wanted to give you one moment just to kind of encapsulate everything that you said regarding um, fatigue and maybe even speak a little bit to the survey that we're doing together. And, we will be putting that in the follow up email. Just letting patients know, the importance of, understanding patients' fatigue and what we're hoping to do here.
Absolutely. So there's been plenty of studies historically, and I say historically, like even 3 years ago, right? Like we know fatigue, back then, but with new treatments, people living longer, right? We want to just always stay on the ball. Like, how is this a problem that's increasing or decreasing or kind of staying the same? And are there certain things that cause fatigue more than others that we can then address in our next batch of clinical trials, for example, or other interventions, right? So it's a way to gather data so you know the problem, and then potentials, so at least some of the confounders and potential problems, then you can start designing interventions. And it's really important to really kind of quantify that. Then you can go back and design a trial basically to all right, well, we're going to do a dose attenuation, or we're going to do a different schedule. We're going to add these supportive medications for these kinds of folks. Like it's really, really important there. And it's also going to be important for nonprofits like HealthTree Foundation to get grants, right, to show that we've done some work, we know what we're talking about, we need some help, right? So grants are really hard to come by. So that's the other thing is if you want to have more patient support programs, they're not cheap, and would love if anyone has rich friends or neighbors or company contacts, please you know philanthropy is a good thing, and but this is another way to kind of ensure philanthropy continues, right, with government grants and other nonprofits and things like that. So I think it'll help keep the lights on.
Perfect. Could not say it better. Thank you so much, Dr. Cortese, not only for sharing your time with us today, but also for your continued support of lymphoma patients, CLL patients. We just are so grateful for you and also for your support of HealthTree. So thank you so much for joining us today.
It's my absolute pleasure. Good luck to everybody out there. Don't be a stranger. Know you're worth everything, and keep fighting out there. Okay.
Perfect. Thank you so much.
You're welcome.
All right. We're going to go ahead and close out today's session. As I mentioned earlier, we do have our monthly cancer Q&A that is going to be tomorrow at 6 p.m. Eastern. Ahead of that, we do have our Black Health Community Check-in. We would love to see you either of those. If you did put that question about insurance denials, I would encourage you to register for that financial Q&A. You're able to pre-submit that question, and we will make sure that the question gets answered, and you will get a copy of the slides, which will have the answer, but then also the ability to watch the replay at your leisure. Then Thursday the 20th, we have another lymphoma and CLL webinar, Understanding CAR T Therapy. That will be at 2:30 p.m. Eastern Time, and we would love to see you there. We do have our Connect to Cures program for anybody who is not familiar with it yet. If you live in or around any of the following cities, we would love to see you there. This gives you the opportunity to connect with other patients, learn from experts, and connect with others who are going through something similar. So if you do live in or around any of those cities, we would love to see you at our in-person event that is going to be happening later on in this year. And I've got my email address on the screen. Until Hannah is back, I'm always happy to connect with anybody, and we'll get the resources that you may need. And again, want to thank you for joining today and hope to see you at another event soon.